Welcome to Mastering Medical and Part 1 of our Pulmonology Rapid Review. Obstructive lung disease. Every disease in this video traps air on the way out, so they all share a low ratio of forced expiratory volume to forced vital capacity. What separates them is one question asked in the right order. Does the obstruction reverse? Is the problem mucus or destroyed alveoli, and which lobe is it in? Let's start with the split that anchors everything. First, asthma versus chronic obstructive pulmonary disease. A young patient with eczema has episodic nighttime wheezing that improves markedly with a bronchodilator. Both obstruct. One test splits them almost every time. Give the bronchodilator. Does the obstruction reverse? Asthma is reversible airway obstruction. Spirometry after a bronchodilator shows the forced expiratory volume in 1 second improving by at least 12% and at least 200 milliliters, and both criteria have to be met. The story is episodic: nocturnal wheeze, cough, identifiable triggers, and atopy in the form of eczema or allergic rhinitis. Diffusing capacity is normal or even high, eosinophils are up, and exhaled nitric oxide is elevated. If spirometry looks normal but you still suspect asthma, a methacholine challenge will provoke bronchoconstriction at a low dose. Chronic obstructive pulmonary disease is largely fixed. The post-bronchodilator ratio of forced expiratory volume to forced vital capacity stays below 0.70, which is the defining number. The story is a smoker with slowly progressive dyspnea, hyperinflated lungs with flattened diaphragms, and an increased front-to-back chest diameter. Diffusing capacity falls once emphysema dominates, because you have lost the alveolar surface that gas has to cross. One exception worth holding: a young non-smoker with emphysema should make you check alpha-1 antitrypsin, and we come back to that in a moment. Now split COPD itself into its two classic phenotypes. A smoker has a chronic productive cough with cyanosis and pulmonary hypertension. The exam decides this one on which word dominates the stem. Is it mucus or is it destroyed alveoli? Chronic bronchitis is unusual because it is defined by a clock, not by imaging. A productive cough for at least 3 months in each of 2 consecutive years. That is the whole definition, and the exam tests it literally. Pathologically, you get mucus gland hypertrophy, which is what the increased read index measures, plus mucus plugging, recurrent infection, chronic hypoxemia, secondary polycythemia, and eventually pulmonary hypertension. Diffusing capacity is relatively preserved because the alveoli themselves are still there. Emphysema is destruction. Alveolar walls break down, so you lose surface area and elastic recoil. That gives air trapping, hyperinflation, a barrel chest, pursed lip breathing to splint the airways open, weight loss, and increased lung compliance. Diffusing capacity is genuinely reduced, and that is your single best discriminator between the two phenotypes. So ask what the stem is dominated by: sputum and cough, or destruction and air trapping. Stay with emphysema and split the subtype, because this is one of the cleanest questions in all of pulmonology. A young non-smoker has early lower lobe emphysema and abnormal liver enzymes. Which lobe is affected? Upper means smoke, lower means a missing enzyme. Centriacinar emphysema is the smoking pattern. Smoke is inhaled and does its damage where it lands first, at the respiratory bronchiole, and it is upper lobe predominant. Panacinar emphysema is alpha-1 antitrypsin deficiency. Alpha-1 antitrypsin is the protease inhibitor that normally restrains neutrophil elastase. So if you have none of it, there is nothing protecting any part of the sinus, and the entire sinus is destroyed. That disease is lower lobe predominant. The second half of the alpha-1 story is the liver. The misfolded protein accumulates in hepatocytes as Pas-positive globules, so you get liver disease alongside the lungs. That combination, a young non-smoker with emphysema and abnormal liver enzymes, is the exam handing you the diagnosis. Ask about the risk factor first, then the lobe, then whether the whole sinus is involved. A quick one that is pure definition and exactly the kind of point people give away. Is this a cough for a few weeks after a cold, or a cough for 3 months a year across 2 years? Acute bronchitis is a short-lived cough after a viral upper respiratory infection. It can last a few weeks and it can be productive, but the chest film is normal, which is what separates it from pneumonia, and antibiotics do not help because the cause is viral. Chronic bronchitis is the duration definition we just covered. 3 months per year across 2 consecutive years, in a smoker as part of the COPD spectrum. The reason this pair is worth 30 seconds of your time is that the exam will give you a cough and a smoking history and expect you to check the timeline before you commit. Count the months. Last pair, and it is a category error the exam loves to exploit. A child with recurrent Pseudomonas infections, pancreatic insufficiency, and failure to thrive develops bronchiectasis. Here is the trap. Bronchiectasis is not really the competitor to cystic fibrosis. Bronchiectasis is the finding. The question is whether cystic fibrosis is the cause. Bronchiectasis is permanent dilation of the bronchi, and on CT you see airways that are wider than the artery beside them. Clinically, it is chronic daily purulent sputum, recurrent infection, and hemoptysis. Plenty of things cause it. Prior severe infection, obstruction, immune deficiency, allergic bronchopulmonary aspergillosis. Cystic fibrosis is one specific cause, and it declares itself by involving the whole body. The defect is in the cystic fibrosis transmembrane conductance regulator, so chloride transport fails and secretions everywhere turn thick. That gives you the lungs, but also pancreatic insufficiency with failure to thrive and fat-soluble vitamin deficiency, meconium ileus in the newborn, and congenital absence of the vas deferens causing male infertility. The confirming test is a high sweat chloride. So when you see airway dilation, first name the finding, then ask whether one diagnosis explains the pancreas, the gut, and the sweat as well as the lungs. Let's lock it in. Asthma reverses by at least 12% and 200 milliliters, while COPD stays fixed below a ratio of 0.70. Chronic bronchitis is the 3-month, 2-year definition with a preserved diffusing capacity, while emphysema is destruction with a reduced diffusing capacity. And smoking gives upper lobe Centriacinar disease, while alpha-1 antitrypsin deficiency gives lower lobe Panacinar disease plus liver involvement. Acute bronchitis is a post-viral cough with a normal chest film, while chronic bronchitis is the strict 3-month, 2-year pattern. Bronchiectasis is the airway finding, and cystic fibrosis is the multisystem cause, confirmed by a high sweat chloride. And the habit for this whole video: reversibility first, then diffusing capacity, then which lobe. That is part 1 of pulmonology. Part 2 moves to the other side of the spirometry curve: restrictive disease, the interstitial lung diseases, and the pneumoconiosis. See you there.